Good morning, everyone. My name is Sarah Al Qassimi, and I'm currently a fourth-year internal medicine resident at Cleveland Clinic, Abu Dhabi. I'd first like to take the opportunity before presenting the case to thank all of the committees for allowing me to present the case to you all this morning. Without further ado, we have a 31-year-old Emirati female who began to develop recurrent fevers and a sore throat that she was just treating conservatively with at home. 2 days later, she began to have epigastric abdominal pain that also improved with her own analgesics at home that she was taking previously. However, 2 days later, her pain became more diffuse and worsened in severity. And the next day, her fever began to reoccur as well, up to 38, 39 degrees Celsius. Because of these new symptoms, she opted to present to the ER for further management. On further history taking, we find that her past medical history was only significant for a history of recurrent tonsillitis that spontaneously resolved as per the patient, and she herself has no personal history of arterial or venous thrombosis or miscarriages and takes no current medications. Her surgical history was only positive for an EGD 2 years ago that showed mild gastritis, and her family history was only significant for colon cancer in her elderly father. In the ER, her vitals showed a temperature of 38 degrees Celsius, but she was otherwise hemodynamically stable on room air. On physical examination, she appeared distressed from pain. Her abdomen was non-distended with exquisite rebound tenderness on the right upper quadrant, and she had a positive Murphy sign. Lab investigations showed a leukocytosis of 16.6 and a CRP of 81.7, but other labs were all within normal range. She had a CT abdomen pelvis done that was suggested of a perforated hollow viscus. And here are the CT images. The arrows are pointing to areas of free gas in the right upper quadrant. Of course, at this point of this case, it was considered an abdominal emergency and general surgery were called. And she underwent an emergency laparotomy that was converted into a right hemicolectomy. Intraoperative findings show loculated gas in the mesentery around the second and third part of the duodenum, as well as a sealed perforation at the hepatic flexure due to the presence of duodenal adhesions. They had taken a biopsy of the resected colon, which was consistent with ischemic bowel, and they had also taken some lymph nodes around the area that returned back with hyperplasia and no evidence of granuloma, malignancy, or amyloidosis. At this stage of the case, I would just like to take a pause and go back in time, a little further in time in the 19th century when Rudolf Virchow first suggested the triad for thrombosis, which consists of stasis, hypercoagulability, and endothelial injury. In constructing a differential diagnosis for our patient, we had used this both as a framework and a guide. The immediate and first thought was to rule out hypercoagulability disorders in all of its deficiencies, followed by etiologies of endothelial injury, which consisted mainly of vasculitides as well as inflammation to the GI tract in particular, where her pathology had first occurred. Stasis was not considered to be a contributory factor in her because she did not really have much risk factors for that. So after her discharge, she was seen first by hematology and underwent a hypercoag workup, which was only positive for lupus anticoagulant at a borderline titer of 1.3, and our upper limit of normal is 1.2. And because she had a bowel perforation, and after a risk-benefit discussion with the patient at this point when they were not really sure of the diagnosis, she was started on rivaroxaban. So unfortunately, all of the lupus anticoagulant repeats afterwards were positive, although remained borderline. So that was felt more to be due to anticoagulation rather than a diagnosis of antiphospholipid syndrome. She was also seen by GI and underwent upper and lower endoscopies that were both normal. She also underwent an MRI enterography that showed no evidence of IBD. And finally, she was seen by rheumatology and had the usual battery of autoimmune workup done, which was only positive for an elevated ESR, but otherwise negative findings. At this stage of the case, they were focusing in an attempt to give her a diagnosis. They were thinking of causes that could cause inflammation in a young patient, and had an MEFG gene testing done, which came back positive for 3 heterozygous alterations with uncertain significance. Based on this, she also underwent an amyloid protein level that was mildly elevated, but had a normal UA and normal renal function so far. Now, due to the presence of her ethnicity being an Arab and her clinical presentation, her abnormal gene testing, and extensive negative workup otherwise, Her findings were deemed to be consistent with familial Mediterranean fever, and she was commenced on colchicine. Now, 3 years later, in 2024, she remains compliant with these medications and with outpatient follow-up at our rheumatology department and has been doing well, completely asymptomatic since that time. The key messages that I would like to impart on today's audience is that this case sheds light on the clinical diversity of FMF in a non-Mediterranean population, or in an Arab population in our case. It also highlights the adjunct role of genetic testing in atypical and silent cases, as we were all taught in the textbooks that FMF presents as an acute febrile serositis that usually spontaneously resolves on its own. And in the end, maintaining vigilance in searching for FMF, especially these types of FMF, can potentially prevent long-term complications such as amyloidosis by initiating early therapy with colchicine. These are the references that we had used. Thank you very much for your time and attention. Happy to take any questions.
Well, thank you. The previous session started with one part which confuses me also, which is CMV, EBV, and T-cell lymphoproliferative disorders and autoimmune diseases and inflammation. And this one starts the same with familial Mediterranean fever and antiphospholipid syndrome. These are all scary abbreviations for me. So thank you for doing it to start. I'm quite taken by the fact that colchicine is used as an anti-inflammatory drug. And it just reminds me that according to what I read recently, this may be the best anti-inflammatory drug following myocardial infarction. We just wrote about it in McMaster textbook of internal medicine, which I want to remind you, you have available. So we will have here a combination of hematology and rheumatology and infectious diseases. Florence, the first, you have the first, but you have a corner of comments there.
Yes, I just have a few. Thank you very much for a very intriguing presentation, because as you can imagine, that particular presentation for FMF is quite unusual. I was just wondering if you knew in general when bowel perforation does occur in FMF, what would be the usual history that you would expect of a patient to have that kind of outcome in FMF?
So in searching for the literature when we were preparing this case, we had only found one case report of bowel perforation in FMF. But after a biopsy of that patient's colon, it seemed that that was more caused by amyloid deposits itself. And unfortunately, that patient did not have a good outcome and had passed away after a long stay in the ICU. So that one case did not have a good outcome.
Okay, and then just another question. So there are the Eurofever criteria for the diagnosis of FMF. And here we have, if I understood it very quickly, 3 mutations which are considered of uncertain significance. So you need the clinical factors as well. So did you reach those criteria for FMF diagnosis?
So for this patient, she had only fever mainly. And I don't know if we can consider the abdominal pain as criteria as well. But the issue with the criteria is that it only is constrained to clinical manifestations, and the addition of a genetic testing to the criteria is not really officially added, but to newer cases now, they are looking towards adding that to the criteria as well. So by criteria, she does not fulfill everything, but because the genetic testing is positive, she is considered a case of FMF.
So I have my neighbor here who's very impatient to ask a question, so I'm going to pass her the microphone.
Thanks. I was going to follow that on. My personal interest being I'm a non-Mediterranean person with FMF. Have you considered other periodic fever syndromes? So cervical adenitis, aphthous ulcers, are features of many others, but not particularly FMF. So PFAPA would probably be the most likely one. And we know that up to 30% of people with that and other periodic fever syndromes are heterozygotes for the MFV genes. So I suppose the question is here, how much weighting you put on the genotyping and how much are you putting on the clinical entity and the history that the patient gives you? Or do you think the tonsillitis is unrelated and truly tonsillitis?
So we were thinking that the tonsillitis could be part of her FMF, although an atypical finding. And again, we did consider the other autoinflammatory disorders, but we decided to go with common. Common is common. In the end, we decided to test that in patients, Arab patients with our ethnicity. We decided to start with that. And because it was positive, the trial of colchicine was considered both a diagnostic and a therapeutic trial. And because she did so well on it afterwards and was completely asymptomatic, that was a diagnosis that we had continued to label on.
Thank you. Very nice presentation. Can I ask you to comment on the rationale for using an anticoagulant in this situation and what you plan to do with it in terms of the duration of treatment?
So she is continuously followed both by hematology and rheumatology as well. The initial thought process was that this was a young lady, otherwise healthy, just came in with a bowel perforation. And the most common cause was probably a hypercoagulability syndrome. So they had placed her on it at the time. But now that we have a definitive diagnosis, the last discussion with hematology is that there is some reluctance in stopping this and then keeping her at risk for another thrombotic event. So she was placed on it for a lifelong duration. And the patient was agreeable to that discussion as well.
Yeah, I might suggest that be reconsidered, especially if you're harboring a diagnosis of APLA, in which case that type of anticoagulant is something that you probably should avoid, but something for your thoughts when you go back.
Sure.
Thank you very much, and it would be, we have to follow with the next one, and maybe two of you should talk about this docs in antiphospholipid syndrome a little bit more.
Thank you very much.